I want to introduce another gold sponsor. And, it's AmeriCares. And we have several representatives from AmeriCares. Of course, our board president, who you met earlier. But someone else, a colleague she brought with her, is going to come up and speak with you. And, not all of our gold sponsors are Christian organizations. And you may or may not know that AmeriCares is, strictly speaking, a secular humanitarian organization, but they have a lot of Christians involved. And it's a wonderful organization, and we are thrilled that they're supporting us, and we obviously have a great relationship with them, and I know that they do a lot of work with you. So we have Elikim Tomati Archer. Am I close? Okay. She is the Senior Director for International Partnerships and Programs, which clearly is a very important position. So we have some of AmeriCare's most important people with us this afternoon. Elikim has been with AmeriCares for a number of years. I'm not sure how many years, but maybe you'll tell us. Previously, she was the director for Middle East and Africa partnerships at AmeriCares. Is that correct? Yeah. So you've done a number of very important things at AmeriCares, and I want you to come up and say whatever is on your heart, and I want to thank you and thank AmeriCares. So come on up.
Hi, everyone. Greetings from Stamford, Connecticut. And Mona, there are Christians in New England. Of course, all three of us are here today, so there may be a faith crisis in New England right now. But I'm here with Anne, who is our head of global programs, and Julie over there, who is also our medical officer. And Julie and I, this is our first time here being at the conference, so we are thrilled and I'm really excited to be with you all. AmeriCares is a global health and disaster response organization. We've been around for over 30 years. And we work in a number of programs, but I think there are two that are of particular importance to you. So we do disaster response. So we are responding to Nepal right now. We've been responding to Ebola. We were running one of the ETUs in Liberia in Grand-Bassa County. We are in Sierra Leone with the Ebola. So we do big responses and small responses, the ones that nobody hears about and the ones that don't make the news. But we also work in our global health portfolio. We are working on access to medicine, which is one of the things that I think is relevant to this group. And the previous speaker was talking about access and making sure that medicines and medical consumables reach the hands of the people who need them. This is where AmeriCares work comes in. We've partnered with I think over 1,200 health institutions and community health workers, community organizations all over the globe. We are in about 40 countries with our Access to Medicines program. And we work with you to provide donated free medicines and medical consumables to fill in the gaps that you saw on that shelf. And we work with our partners to build these containers. One of the things in our business, you hear you get containers. Those of you in the field, you get containers of things that like 9% are good, and the other 90% you're like, what am I going to do with it? AmeriCares really works to make sure that we are building with our partners so that whatever we send to you, you have to sign a manifest to say those products are good, are useful, and you can take them before we actually ship the container to you. So that's one of the big programs that we have. The other program that I think is important to this community to know is our medical outreach program. So this is when we support US-based licensed medical professionals, so doctors, nurses who are going on mission trips to a lot of the countries that you all work in. You can sign up online with our program, and then you come into our inventory. So you're going to do fistula work or cleft palate surgeries or whatever you are going to do. You can come in and you need some sutures and analgesics and whatever. You go into the inventory, you apply and you sort of shop for the things that you need, and then we send it to you here in the US, and you take it with you when you go. So those are, I think, the two big programs that are relevant to you. As we evolve as an organization under Anne's leadership, we are really growing our global health portfolio. So we're going to be focusing a lot on working with our partner network on non-communicable diseases that we all know is rising in developing countries. We are also going to be focused on maternal and child services. I mentioned we have a fistula program that we work on. We are going to be looking at the prevention side of things a little bit more. And we are also going to be focused more at the facility level. This is where we think is our greatest strength. And so those of you who are really working in the community, I think that creates a nice partner where we focus on really helping to support and build the capacity at the facility level, integrating with the people who are working on the community level. So we are outside. Please stop by and say hi to us and learn a little bit more about the 3 Christians in New England. And then we'll also talk to you about our organization. Thank you very much.
Thank you, Elikim. And I'm also from AmeriCares as the Senior VP for Programs, but today I am Chairman of the Board for CCIH, and right now I will be moderating the next session on community initiatives that are contributing to addressing poverty. And it's a real joy for me to introduce all 3. Henry Perry and I have, we've paralleled for many of the years. We've been on sessions and speaking engagements and lots of things together. He is the Senior Health Director, I believe, at Hopkins. The students have already greeted him with great joy, and I know he's a fabulous professor, but he's also got just an incredible heart for the community, and that's really important as all of this discussion around health systems is going, and I know that Dr. Perry is really going to help us see that connection between health systems and community. Henry? Yeah, you can go over there.
Thanks a lot, Ann, and greetings to everyone. It's great to see a lot of friends and colleagues from over the years. And hang on just a minute. Okay. Yeah, it's great to see a lot of this thing close to my mouth. Okay. Hi, everybody. Is that better? Okay. So it's great to be here. I've been coming to CCIH for many years. I wish I could be more active than I am, but it's great to be here, and it's great to see lots of friends and colleagues over the years, Milton Amaya and among others. But thank you for the chance to be here. And when I saw that the theme for this year's conference was on poverty alleviation, I immediately thought about BRAC and the possibility of sharing a little bit about BRAC with you. I had the privilege of living in Bangladesh from 1995 to 1999, and so in the course of my work, I came to learn about BRAC. I wasn't actually working with BRAC, but I came to learn about it, got to know a lot of people at BRAC, and I continue to be totally fascinated and mesmerized by this organization. How many people have never heard of BRAC? So that's quite a lot of people. How many of you have heard of it but don't really know anything about it? There are a few of you. And I know there are a couple of people here who know a lot about it, but I don't think there are very many. And it's always surprised me that BRAC isn't better known than it is. But it's the message that I want to give across to you is this is a different approach to development that I think is very healthy, and it's something that we need to know about. And there's so many ways in which it's different, and there's so many ways that it's healthy that I'm not going to be able to talk about it. I've got 10 minutes, I understand now, because we're running behind schedule. And so I'm going to kind of go through some ideas very quickly with you and hopefully whet your appetite so that you on your own will take some time to learn more about it, which I'll explain a little bit more in a minute how you might do that. But BRAC was originally called the Bangladesh Rural Advancement Committee, started in response to typhoon disasters in early 1972, and now it's become the largest NGO in the world. If you talk about the number of people reached by the organization and the number of employees. It may not be the largest in terms of budget, but it's not a small budget either. And it reaches 120 million people in Bangladesh alone, more than 200,000 staff. And it's a very broad and diverse organization. It's world famous for its health work, but the health work is only one small part of what it's engaged in, and I'll explain that more in a minute. And not only that, it has its own university, which is every year becoming better recognized for the quality of its work. And within the university, they have a very famous school of public health called the James B. Grant School of Public Health. I'm not going to be able to tell you about those things today. They have a great website with a lot of great resources in it. I'm going to be referring today to the most recent annual report. Every year they have a very educational annual report that has a lot of substance about their programs, so that's one place that you can go. The vision of BRAC is a world free from all forms of exploitation and discrimination, where everyone has the opportunity to realize their potential. I won't read the mission statement or you can see the values, I think, pretty well. It's a very inspiring vision, but it's focused primarily on women, women's empowerment, and poverty alleviation for families, but through the perspective of women and empowerment of women. Now, BRAC has a lot of different kinds of programs, and these are described to some degree in the annual report. And these vignettes that you see here come directly from the annual report. But they have a vast agricultural program that involves quality seeds and technical support and so forth. They have an integrated development program that's coordinating a whole lot of different activities for the very marginalized people, what they call the ultra poor in Bangladesh. It's not widely known, and this may have changed in the last couple of years. I don't think it has, but BRAC has the largest microfinance program in the world. Everybody thinks of the Grameen Bank with finance, but BRAC's program is actually bigger. But they don't tout that. But it's amazing operation. So they are dispersing $1.5 billion a year to 4.2 million borrowers. And this is all money that has been generated internally through women's groups within Bangladesh. There are a whole series of enterprises that have been developed at BRAC over the last 4 decades or so. And these are profit-making enterprises that have been established to support the work of BRAC in one way or another. And they feed back on helping women's groups throughout the country. Just to give you one small example, one of their enterprises that's not on here is a printing company. So they started a printing company to lower the cost of their own printing needs, and they did it in such a way that it not only served their own organization, but served other opportunities within Bangladesh and became a profit-making enterprise. And they've got many of these, and you can see several examples from this. In the last 10 years or so, they've developed what they call an ultra-poor program. I'm not an expert on microfinance, but my understanding is that microfinance works for a lot of people, but it doesn't work for everybody. And some women don't have the entrepreneurial skills that are needed to really make this kind of program work, and there are other people who are so poor they really can't get into this. And so BRAC has developed special programs to get them out of their ultra poor status so they can move up and be more effective in working with more traditional forms of development assistance that is successful. They have a massive program in water Sanitation and Hygiene. I think their program in Bangladesh is one of the biggest in the world, if I'm not mistaken. And they've just recently completed a major project that serves millions of people. And it's developed in a way that's empowering for communities. They work through communities and community leaderships and make sure that women and their needs are met through their community program. We heard in the previous session about education, terribly important. BRAC operates the largest secular and private education system in the world. Did anybody know that? It's amazing. And the way their program operates is that it's geared towards attracting young people who are in their first, second, third grade who have missed the government education system, and it's taught by local people in the community who are literate, and BRAC provides them with the skills and resources to be teachers. And it's amazing. It's the tremendous success rate in getting students back into the government education program. It's focused on girls. There are a lot of studies that show the tremendous contribution that BRAC has made to the education of girl children. And Bangladesh as a whole has been one of the global leaders, I think, in really improving the education of young girls. They have a lot of other programs, which I don't have time to mention. A very interesting history, starting out with a more conventional kind of program, but very quickly learned about the concept of capture by elites, and they developed a whole approach that worked only with marginalized women and communities that has turned out to be very successful. The backbone of BRAC is the voluntary organization. It's their microfinance group. It's a group of 10 or 12 women who meet regularly every 2 weeks or so, and they contribute money to this. And that capital on a large scale with small amounts of money made it possible for BRAC to begin to invest in these enterprises that supported what women wanted to do in these groups. And just to give you a small example, the way this works is that once you join a microcredit group, you have the opportunity of getting training in an area that appeals to you, whether it's chicken farming or handicrafts. The Mennonite Central Committee was important in helping BRAC start its handicraft program, which is now massive in and of itself. So you can go off and learn about handicraft production or any of these enterprises. You can go off and become a community health worker. They have massive regional training centers where people go to for very serious, high-quality training. And so these village development organizations are what spread throughout the country, and as those spread and as the money that those generate grows, then BRAC is able to grow with its other supporting activities. BRAC's, how much time do I have, Connie? I know I get carried away. 1 minute, okay. So they have this world-famous program of Shasta Shabikas, which are their community health workers who go door to door. And the way this program grows is that the Shasta Shabikas, they sell little products that BRAC produces or buys in bulk to sell to these people, and with small amounts of profit that they earn by selling things, they get enough economic incentive to motivate them to do a whole host of other things which have nothing to do with income generation. So they're selling sanitary napkins or slab latrines or soap or paracetamol for pain medicine, things like that. But they have a deep commitment to serving the entire population. So here's a picture of their village organization. I don't know if you can see this or not, but the red line that starts about halfway across the slide and goes straight up, that's the growth of their Shasta Shabika community health worker program. And the blue line in the middle is the growth of the government community health worker program. So you can see the massive scale up. This is from an article in The Lancet on Bangladesh and community health work. I really wasn't planning to talk so much about their health work, and my time's already up anyway, so can't do much about it. But their health work is world famous for many reasons. They became famous and went to scale with their first activity, which was sending community health workers to visit every home in Bangladesh. I think there were 12 or 13 million of them. And they taught these mothers how to use local sugar, salt, and water to prepare oral treatment for diarrhea. And it's changed the culture of Bangladesh. Bangladesh is famous now because it has the highest ORS use in the world. And it all grew out of this BRAC program. Just to give you one example. Bangladesh has been a global leader in reducing under 5 mortality, and everybody knows that BRAC has made a major commitment to this and a major contribution to this, and has worked very closely hand in hand with the government in many programs, whether it's mobilizing people from immunizations, or they have a world-class TB program where the Shasta Shabikas identify patients and provide the treatment, and the government makes the diagnosis, and it serves most of Bangladesh now. I'm almost finished here, 30 seconds, okay. One of my favorite projects that BRAC has, but I'm enthusiastic about everything they do, is something called the Manoshi Project, which is a program for maternal, neonatal, and child health in the urban slums of Bangladesh. They got a grant of $25 million from the Gates Foundation to establish this program that reaches every household of 7 million people in slums of Bangladesh, and it's had a dramatic impact on maternal and neonatal mortality through home-based delivery of services. I'm going to kind of skip through this, but it takes the right kind of leader to make this happen, and if you have never heard of F.H. Abid, you should hear about him. He's one of the great leaders of our time. He should win the Nobel Prize, but every time I hear him speak or every time I see him, I just feel good because he's one of the wisest and most generous and caring people, but he's crafty as well, and he's the real spirit behind BRAC, and he's been the head and the founder, and he's now, I think, in his mid-70s, but he's done a tremendous job in this. So my time is up, but just let me say that BRAC is now all over the world. It's not in a lot of countries right now, but as you can see here, they've spread into Africa and the Middle East. They have a program in Haiti, and their whole approach is catching more attention. They come in a very low-key way and start forming these women's savings groups, and those start spreading around, and then people know that they're there, and this is their national spread. And there's a tremendous book about BRAC that was published a couple of years ago. I have a copy here if you want to look at it, called Freedom from Want, that talks about the whole history of the organization. Thank you.
Okay. So thank you, Henry. And I have to echo that BRAC is one of my favorite NGOs. It isn't just world-class quality, and we've talked a lot today about sustainability, but this is scale. This is your example of how you do things, and then you scale it up. And so BRAC's the place that many of us can learn from. It's now my great privilege to introduce a fabulous colleague and an old friend of mine. Dr. Susan Hillis is an epidemiologist from the Center for Disease Control. She's worked in reproductive health, in mother-to-child prevention. She's now in their global health department and working with surveys on children affected by violence. But if you get a chance, talk to her about her own personal life. There's stories there that you should hear that are just amazing. And she is the one person I know who can take data and make you cry. And I expect that will happen in this presentation. Thank you, Susan.
Thank you so much, Ann. Can you guys hear me okay? Great. I'm so thankful to be here and so thankful to see each and every one of you. My dream is for the Lord to, as He has placed me on this bridge, a little rope bridge between governments and churches around the world, to always be an instrument of His and pulling us close together to increase our impact for His glory in the world. So it's great to be here with you today. I want to talk briefly about violence against children surveys and prevention works. It's what I've been working on for the last number of years at CDC. Imagine if when you woke up this morning, you either looked at the news on your, whatever you look at it on, your little handheld or a newspaper, or computer and you read a story that said scientists had discovered a new disease in the world, it was affecting 1 billion children ages 0 to 17, 1 out of every 2, that it was entirely preventable, and if not prevented, it would lead to an increased risk their whole life long in every single major cause of disease and death in the world: heart disease, cancer, diabetes, chronic lung disease, suicide, reproductive health causes of death and disability, and infectious diseases like HIV and STDs. What do you think we would do if we read this article and we knew that a cure was relatively feasible in every country of the world? Well, of course we would say, well, we're going to stop that. Well, the truth is we do have such a disease. It's called violence against children, and I think it is the new tobacco of the 21st century. Just to put this in context, I will say that violence against children is not something that has preferential prevalence in countries that are developing. It is a problem that affects every country of the world. This is our own data from the United States. I just want to call your attention to the first bar. In the previous year, every year, more than 60% of children in the United States experience violence, either physical, emotional, or sexual, or exposure to community violence or violence in their homes. I'm working now with some colleagues at the CDC and Harvard on a paper. I'm so sorry this is in Spanish, but I actually literally just got back late the night before last from Colombia, South America, working on this, and I only had a Spanish slide, so that's why it's in Spanish. But these are regional estimations of exposures to violence against children during the previous year using 2014 census data. And what I want you to really think about when you look at this is the world is on fire. What we see is in Africa, rates of violent exposures among children, serious ones, any type of violence is 80%. In Central and South, in Asia and Russia, roughly 70%, over 70%. In Central South America, 60% or more. In the United States and Canada, 50% or more. And in only one region of the world are rates of violence against children less than half, and it's Australia. Why is this so important? We know from the Adverse Childhood Experiences study that Frank had mentioned. I was actually involved in that with CDC, the very first one in the late 90s, that when children are exposed to violence, particularly in early ages of life and up to about 17, that ends up causing increases, as I was saying in this early, suppose you read the newspaper story, of every major cause of death and disability in every nation in the world, whether it's chronic diseases, infectious diseases, problems related to maternal and child health, mental health problems like suicide or injury. Sorry, I don't have time to go into this, but I'm happy to talk with you about later if you're interested. Those relationships that I was just talking about, there are now hundreds of studies from countries around the world, even ones now led by the WHO in 24 countries, showing those associations that I just spoke to. However, the basic science that underlines those empirical associations has just been elucidated within about the past 7 years, and Harvard has been a big leader in this. But what we know basically now is exposure to that kind of violence in childhood damages the brain. Now we have actually more than 80 studies from 19 countries documenting this. On the left-hand side of this slide, you see a cross-section of the brain of a child growing up in a stable, secure family, and you see the temporal lobe areas in those little circles show activity. On the right-hand side, you see a child growing up in an institution, and what's shocking is it actually looks like part of the brain is missing. Well, what happens is that those parts of the brain just don't develop if children are exposed to chronic stress in early ages. CDC has been asked to assist many countries around the world in implementing national representative household surveys of 13 to 25-year-old youth to help measure the prevalences of their exposure to violence growing up. I show there in the red list all the countries where these have been completed. The completed list, if you're working in any of those countries, the results should be available in a report online. The ones in progress are in the green countries, and the potential ones are in blue. And I will say that China now is switching into a green country. We will be working in China, and Colombia also will be the first country in the Spanish-speaking world where we will be implementing these. We actually provide technical assistance from the CDC perspective for countries to implement these surveys. They measure exposures to violence, and then they use that data to link it to political engagement and programming. We implement these, we provide technical assistance for the implementation as part of a very large public-private partnership, and it's only getting larger with the new sustainable development target of eliminating all violence against children around the world in the next 15 years. Let me show you why this is important. This little black line on the left shows if you just measured police reports or hospital reports of cases of violence, whether it's rape or child abuse or maltreatment against children, you would get about a 0.4% global prevalence because people hide it. Like, they don't take kids often. If children are being abused, how are they going to get care? They're going to get care if someone takes them in for care. And often this is very hidden around the world. So if you measure the prevalence of such exposures in household surveys around the world, this is just sexual violence, so this is not any violence. It's 12.7%, 30 times higher. So now it's very clear that the gold standard methodologically for getting a handle on how bad the problem is direct report. We're not going to get it from facilities. I'm not going to go into the methods because I know we're short on time, so I'm just going to rush through a few of the findings that we are learning, and that is here you just see the prevalence of sexual violence before age 18 reported by boys and girls in 7 of the first countries that we completed. And what you see here is this is just the sexual violence, not any violence. And you see that in African countries, 22% to nearly 40% of the girls had experienced sexual abuse in childhood growing up. This is causing horrible damage in those children and in the young adults throughout their whole life. What has been previously unappreciated is the problem is also serious in young boys. Here we see roughly 10 to 20% of boys the same. It only gets worse if you look at physical abuse, and we're not talking about mild spanking. We're talking about whipped, slapped, beaten, fractured, burned, injured. Those types of levels of physical abuse. And again, in almost every country for both boys and girls, rates are roughly 50 to 75%. There are some categories of children that are particularly vulnerable. Particularly orphans tend to be, and here you see the sexual violence and emotional violence tend to be particularly elevated among those groups. That's a group I care a lot about. My husband and I have 11 children, 1 in heaven, 10 grown up, and their ages are 21, 22, 23, 24, 25, 26, 26, no 27, 28, 29, 30, and 8 of them were adopted from orphanages at older ages, and they had all experienced this kind of abuse I'm talking about. And I'm telling you, I see some of you shaking your heads because you know what I'm talking about. I see that with the love and power of the Lord through parents and through loving communities and through His mercy, it is definitely possible for restoration to occur. But wouldn't it be a lot better if we would prevent it from ever occurring in the first place? So the thing that these surveys do is a little bit, you know that star slide I showed in the middle, in the beginning with the red violence against children in the middle and all those other consequences around the edges of the slide? These surveys actually show for a given country how common the violence is and then the presence of those very complications in their population that's being interviewed. So nearly 4 times the risk of either HIV or STDs, 3.5 times the risk of pregnancy complications, 2 or more times higher risks of suicide. So countries tend to take the data seriously and take very seriously developing policies and programs because they see it's already at these young ages having very destructive impacts. Remember the red and black slide where I showed you the prevalences if you get self-report versus if you get services reports? Here, I just want you to pay attention to this little upper gray triangle. And yeah, this is just for the data of Kenya, but it's about the same in all the countries. And that is the proportion of all those girls who received any services for their sexual violence was 3.4%. And for boys, it's less than 1%. So if we're getting our estimates of how bad the problem is from service delivery, official sources of data, we won't know what it is. The thing that has been very rewarding for me about this is that the very process demands that action be taken. So CDC goes in with UNICEF with conditional engagement. We're only willing to work with the country if the country is willing to set up a multi-sector task force that has a government ministry lead, like Ministry of Health, Ministry of Social Services, and the other government ministries have to be involved: health, education, finance, justice, etc., universities, faith-based groups, other multilateral or bilaterals like World Vision or World Bank, and U.S. government if we have presence in country. And what this data really does is it breaks the silence about a subject that is often taboo, and it guides action. Here I just want to show you that Swaziland was the first country we were able to do the survey in 2008. And in that year, 2008, of the survey, the Pan-African Child Policy Forum, a group of policymakers for the continent, ranked every country regarding the child friendliness of their policies. Swaziland was in the bottom 10. Here, within 5 years after the survey being completed, because of the action it drove to protect children, Swaziland jumped, and now it ranks in the top 10 best countries for how child-friendly their policies are. I just want to show this graph of what has happened to child sexual abuse in the United States. Things like this that are this bad can go down instead of up. And I want to close by saying it has been my honor and job for the past year at the Centers for Disease Control to lead a group of scientists in researching the data around the world, randomized trial experimental or quasi-experimental designs, to identify what is it from the evidence base that would be effective, a core set of simple interventions that together would be effective at preventing this violence. This is on the web, the CDC web. It went live a couple weeks ago. There's a full compendium that describes it. We're now working with an World Health Organization, PEPFAR, USAID, et cetera, to unify across the agencies this technical package. But I actually feel like the Lord gave me the acronym THRIVES, and it's what He would desire for children, not surviving. T is training and parenting, positive parenting for caretakers. H, household economic strengthening, like the BRAC model. R is reduce violence by legislative protection and enforcement. A, improve services for victims, particularly the community health workers are great models. Value norms that protect children. Strengthen education, like Frank Dimmock was talking about, and build life skills. And then you have to have data to monitor progress. This just shows that whether you look at CDC, PEPFAR, the USAID Gender Strategy, UNICEF, or WHO, already almost the whole world is agreeing about these components. We just haven't been calling them the same thing. And so we are optimistic that as we're moving into the Sustainable Development Goals, this will become like a standard approach about the way we talk about preventing violence against children. I'm only showing you this because I know there's a lot of stuff on it. I don't really want you to pay any attention to it, but I do want you to know that we already have live on the web implementation resources for every one of these components. So if you were thinking, oh, I would like to see how do you implement those theoretical strategies Susan Hillis was talking about, you can go to the slide and click on some of these sites and it'll show you what you could do. I'm excited that I believe the Lord wants us to move from a vision of surviving to a vision of surviving and thriving for children He cares about. Thank you.
Okay, thank you so much, Susan. We're on to our last speaker. Janet Strike Ausel is an engineer for Samaritans Purse. I told her a couple minutes ago, I think our next greatest innovations in global health will be when we do things intersectorally, when engineers talk to health people, when health people talk to education people. She has a master's in engineering, and she's going to talk to us today about water and sanitation. Thank you.
Terrific, thank you. I tease my colleagues at Samaritans Purse that it's all about water, and today the weather agrees with me. So, so thank you. I'll try and make it quick. I know we're behind time. If I was to give you a standard WASH presentation, it would go something like this. Over 748 million people still do not have access to improved water supplies, and in reality, the access to clean water is less than that. A third of the world's population doesn't have access to proper sanitation, and over 1 billion of those still practice open defecation. And hygiene studies have to do with amazing impacts in health in the communities that we work with. And you know all those things. But today I want to say, if we stop there in our WASH programming, we've failed, or we've done much less than we could be doing. If you look at what we could be doing, and if you heard, I'll just give a quick shout out to the Children with Disabilities talk that happened this afternoon. If you heard that talk, you understand that Christ's heart for people is way bigger than just improved health impacts. And I think that you all agree with that. It's not just about having access to clean water in order to have healthy outcomes for people. Psalm 64 talks about God's heart as a father to the fatherless, a defender of the widows. He's setting the lonely in families and leads the prisoners out with singing. And his heart is for way more than just our health. And so I wanted to talk a little bit today about some of those things. I'll start with just a story from one of our WASH programs in Kenya. In Kitui County, we were working in a village that had spent 2 years without a working well. They had a diesel-powered pump that had broken, and so for 2 years, people were going multiple times a week on a 6-hour journey during the driest seasons. Obviously, during the driest seasons, it's also the hottest seasons, and people were often then trying to do it under the cover of darkness. So you can imagine the impacts that had on people's lives. They didn't have any excess water for livelihoods. There was a local preschool teacher said, "I was afraid of animals, robbers, and thugs." But the village leaders went beyond that and said that there were cases of sexual assault against girls and younger women as they traveled to these points. There was a major impact in their lives. Samaritans Purse went in 2014 and provided a solar pump. And, so for these 500 people, 500 families rather, there was a much larger impact that these families had not, were positively affected. Some of the village leaders said, I see it as improved for the community life. Education has gone up, church attendance had gone up. Children are no longer out of school due to sickness. They have sufficient water for hygiene. They built a bank of shops next to the well. So it improved both economically, socially, and a whole bunch of impacts. And as we're short on time, so we'll kind of glaze through these real fast. But you can see if a nearby source of safe water is not just about clean water for health. Obviously, that's a big one, but it also provides opportunities for reduced sexual violence or harassment for women, more time for micro businesses because they don't have to go as far, more time for these girls who are often responsible for fetching the water. So all sorts of different impacts that you see. And a nearby source of safe sanitation is also very similar. A lot of these urban and rural contexts, a lot of girls, and as we were talking about this over 1 billion people who still open defecate, they reduce their water or their food intake for the day so that they don't need to face an embarrassing situation, and they'll only go out at night. Now, of course, if they only go out at night, they're also exposing themselves to further risk. So a nearby source of safe sanitation reduces that impact of sexual violence. There's more privacy and therefore more dignity. There are tons of taboos, which I'm sure you're all aware of, surrounding defecation. And so without those sorts of protection, people are, women and girls specifically, are more inclined to a much higher risk. One of the things, I've got a little riddle up there for you. As an engineer, and I'm perfectly comfortable talking about filters. I'm perfectly comfortable talking about how to build a good latrine. What I'm less comfortable talking about, and what most of the world has been less comfortable talking about for millennia, is menstrual hygiene. Does that make you all uncomfortable? Yeah, probably. But it is starting, the good news is it is starting to hit the radar of people. This was if you follow NPR, this was an article that was posted just in the last couple weeks, shows a group called Be Girl, and who has created a set of underwear with an impermeable bottom and areas to put in whatever reusable material or non-reusable material you can to take care of menstrual issues. And there are lots of other organizations coming in and starting to talk about these things. Days for Girls, AfroPads. There's a number of different resources that I could provide for you. But what is the real issue, right? So real issues that we have are education. It's shown that about 23% of girls drop out of school at the age of starting their menstrual cycle. That there is lack of access. Girls and women typically have less control over financial resources in the family. They have less access to, so that leads to less access to menstrual materials. They are not able to, afford things, disposable pads, that sort of thing. So women use all sorts of other products. They use rags, sand, sawdust, ash, whatever that they can find to take care of their flow. And one of the things that happens if they've got reusable products, which we say, oh yeah, that would be great, reusable products are wonderful, but then you need a safe place to dry them. And if you put them out in the sun, then they can be disinfected or pasteurized, and frequently women are too embarrassed. And so how do we provide those sorts of protections for women? We found our Cambodia office told me when I was on the phone with them the other day that up to 70 or 80% of the women had recurrent yeast infections. That's an extremely high number, and often very hard to get rid of. So, one of the other issues is that men and women need to know about menstrual hygiene, and it's obviously not a topic that men typically want to engage in, but that leads to a lot more taboos, a lot more myths surrounding menstrual hygiene issues. So another good area that, as I said, some of these things are starting to change. This is a picture from our distribution after the Nepal earthquake just recently. For years, as long as I can remember, we've included menstrual products in our hygiene kits. Which is great. But for the first time I saw with the National Wash Cluster, they came out with hygiene training materials that included an exclusive section on menstrual hygiene, which is the materials you can see on the right. I can't read them, so if you know anybody who knows Nepali, you can get them to interpret. So what do we do, right? In our programming, I would hazard a guess maybe at least half of us have connections with organizations or work with organizations that could include some sort of menstrual hygiene programming in your health programs, in school programs. There are a lot of resources out there. One of the things I think that we need to do is approach programming with incredible grace and sensitivity and building trust. We need to know what the myths and the taboos are. We need to build trust with the people that we're working with in what can be an extremely sensitive issue. So if you see up on the screen here is a program called Growth and Changes. It's a manual that's been published in Tanzania. There are similar ones in Cambodia. I know Uganda has its own national curriculum where they've started looking at some of what the taboos and myths are. They provide these to schoolgirls and train teachers how to use them. And if teachers are uncomfortable with them, at least the schoolgirls still have a very valid source of information that they can use in order to get good data on what's happening with their bodies. Hardware-wise, we do a lot of programs. Samaritans Purse does a lot of programs with wash facilities. Are we providing latrines that have locking doors that people can't see through or around? Are we providing places that are hygienic in order for people to deal with menstrual issues, that they can do them privately, like I said, with locks and that sort of thing, in safety and with dignity? Do they have places to dispose of menstrual products within their latrine and not have to carry them out somewhere that they might be exposed? So let me give you a couple of quick examples. I know I'm running short on time. But our Water for Kids program has been around for years, and just recently has started to incorporate some of this programming in it. So we provide training to the teachers and the school support committees, and those teachers and school support committees then end up being champions for menstrual hygiene with the girls. We found some just very preliminary data since we've started this, but what we hear back is the training gives teachers more confidence. The girls know and appreciate having those feedback from the teachers and being trained by the teachers, because they don't necessarily trust the members of their family to be giving them accurate information, or don't know that they have accurate information. And we're doing a lot more. We're currently just about to embark on a study identifying taboos, cultural barriers, and opportunities to do additional programming. Another place that we are just pioneering is our Northern Uganda office, or Northern Uganda group has done their homework. They found that 84% of girls missed school during their periods. That they change their behavior. They're less willing to stand up and be in front of the classroom to engage in sports activities. Many of them don't have knowledge about menstrual hygiene prior to starting their periods. Pads are cost prohibitive. I can kind of go on and on. There's a number of taboos. In that area, they say women can't go out to garden because it will cause the G-nuts to dry up. And a number of the churches say that women are unclean during their cycle and are not allowed to come to church. So there's all of these different factors that they've started to identify, and the program that they've designed and are about to implement hits a wide range of those groups. So it starts with community sensitization with pastors and with the leaders as well, and works with the parent-teacher associations and with the school health clubs, and then making those kids the champions to other kids and other girls. So they'll teach them how to use this bracelet that you see up there, and also work with a group called Days for Girls, which I mentioned earlier, that has will teach the girls how to make homemade menstrual products, which they'll be able to sew on their own without a sewing machine, and then have a reusable pad there. So they're also doing hardware too in these schools that don't have private spaces for girls and don't have hand washing stations and those sorts of things. So I know I'm out of time, but just sort of in summary or as an overview, I really believe that it's important that we see wash, water, sanitation, hygiene just not as simply a health issue, but that it's an opportunity to care for the whole individual as the half of the population that's also made in God's image, and protecting those who and serving those who are in vulnerable places. Thank you.
So the Bible's a pretty straightforward book, and I think the people of faith need to tackle some sensitive issues, whether it be menstrual hygiene or violence. So I really thank panelists for being brave. We've got time for maybe 2 questions, and then you can come get these guys afterwards, here and then here. Go ahead.
One question for Janet. We have a ministry in Haiti, and in the past, we've built, or others have built some wells, but the problem is maintenance. What do you do to make sure that some of these things are maintained properly and that 3 years later, they're broken and can't be used?
Yeah, absolutely. That's one of the biggest challenges with any water source installed anywhere in the world, and I think that you're not unique. Samaritan's Purse has the same challenges. We try and mitigate those, especially by training hand pump mechanics in these areas. I believe that there's a lot more work that can be done for follow-up and continually retraining, building into the government systems. So there's a lot of, and there's some other potential ideas that are coming out. We've seen a couple of programs that use like a circuit rider system where the communities enter into a contract with service providers that are then contracted to go and visit these wells on a regular basis in order to prevent that. That's not something that SP has done, but it's a project that we'd like to try and pilot at some point as well. There's no easy answers. Training certainly helps. Behavior change in any of the programs that we do is one of the big issues, and I think a lot of maintenance has to do with behavior change as well.
Hi, my name is Naveed. I'm from Pakistan. Thankful to Lord for providing us opportunity to be here. And secondly, thankful for thought-provoking and informative presentation. Would like to know about the BRAC scale of work in Pakistan. Thank you.
Actually, I don't know anything about BRAC's work in Pakistan, I'm sorry to say. I wish I did. But this gives me a chance to make a quick point, if I can, because I was going so fast to meet my time schedule. There was one key point I forgot to mention, and that is about, you see different figures, but somewhere between 70 and 80% of all of BRAC's resources are internally generated. And so everything they do, all the donor support they get is directed towards developing things that are sustainable in the long term without donor support. And so that's a critical part of their operations. So thank you for giving me the chance to say that, but I can tell you that you can learn more about it on their website. They have a annual report for Pakistan. Every country they're in, they have an annual report, and you can get it very easily.
Okay. One more question here, and then Milton we'll stop with. Sorry.
My name is Alicia Veselkowski. I'm a mechanical engineering student at Seattle Pacific University, and I have a question for Janet. I'm wondering if SP or any other organization you know of has measured the impact of menstrual hygiene programs.
Yeah, well, any of our projects that we embark on have a monitoring framework, and so we do measure that impact. As you saw, most of our projects are extremely new, so we don't have any data on the impact. We will be doing it as we do more programming. And so I have seen, gonna have to go back and take a look. I think that I have seen some data on the impact of some of this programming, and I can't tell you what it is off the top of my head.
I'd actually go and look at BRAC, because BRAC has done some of the menstrual hygiene, and they have at least some data on girls' school attendance going back up as you make these available. And then Milton Amayan right here. Last question. Sorry, any of the others, please come forward after.
Milton Amayan from International Care Ministries. Thank you, Henry, for that presentation. I work for an organization that focuses on a new word that you introduced today, ultra-poor. And this morning we were talking about extreme poverty, absolute poverty, but many of us don't know about the ultra-poor. And I didn't know anything much about the ultra-poor until like 2 months ago when I started working with International Care Ministries. We measure the amount of income that the people live on, and we have chosen to work with the ultra-poor, those who earn in the Philippines 50 cents per day. And that is our focus. And thank you for introducing BRAC, because many of the things that you talked about are actually being implemented by International Care Ministries. My question for you is, how did BRAC, because you're not BRAC really, how did BRAC transition from being an organization that received aid from the outside to being a very entrepreneurial, very business-oriented NGO?
That's a great question. F.H. Abid is an accountant by background originally, and he worked for Shell Oil Company at the time that this disaster hit Bangladesh in 1972. And so he came from a business background. And I think that has certainly been a major part of why BRAC developed this focus. But I think part of it is that they were just sort of the beneficiaries of good luck. I've talked to a lot of people who have spent their lives working in BRAC, and the sense that I have is that the way these village organizations grew so rapidly, it provided them with capital, and they needed to do something creative with it, and they've done amazingly creative things with it. And so it was an organic process. It wasn't planned out that way to start with, so it's an interesting question. Yeah, but I'm a big admirer of leadership and all that leadership entails in making programs work. And BRAC, has had the kind of leadership that we need so desperately in development.
Okay, thank you all for coming. I'm turning it over to Kathy, it looks like, or to Mona for